Dr. Kumar, the first anti-BCMA therapy was recently approved for relapsed refractory multiple myeloma. Why is this a target of interest for multiple myeloma?
Right. I think the BCMA, in general, the immunotherapy, all of them seems to be quite effective based on the initial data. BCMA or the B-cell maturation antigen is a target that has not been used from a therapeutic intent up until now. The good thing about BCMA is it is present in all myeloma cells, on all myeloma cells, and does not really seem to change much over the disease course. Suggesting that this could be a target that or an antigen that could be targeted multiple times along the course of the disease evolution. So that is one is the expression part of it, and it seems to be relatively limited to the B cell lineage. So the toxicity outside of that those cells might be limited. Especially when we are using the other immunotherapy approaches without, different than the belantamab that was just approved. And then, and obviously the patients, at this point, very few patients, if any, have seen any therapy that's targeted to BCMA. So it'll definitely be a new kind of treatment naive for most of patients.
Okay. And what were your thoughts on the study data from the DREAM2 trial for which the FDA approval was based?
Right. So the DREAM2 was essentially a large phase 2 study, right? And, it is compared to what historically we would have anticipated from those patient populations. So it's a heavily pretreated group of patients. Most of the patients had like 5 to 6 prior lines of therapy. Majority of the patients had seen the currently available agents. They looked at two different drug doses or two different doses in that study. Both of them had equal number or nearly equal number of patients. The efficacy seemed to be quite comparable, but I think from a toxicity perspective, the lower dose appeared to be better tolerated, and that is what is moved forward and is currently on the label, which is the 2.5 milligram per kilogram. They did have a, close to a little over a 30% response rate in this heavily pretreated patient population. The overall PFS, wasn't very long, but in patients who did get a response, the duration of response was close to a year. So it's clear that people who respond to the therapy have durable responses. Now, obviously, a significant proportion of patients did not respond. And those patients, some of them did have stable disease, which can be quite meaningful in this late stage of the disease. But for the people who did not respond, the big question is going to be, can we get some benefit from this therapy by maybe combining it with other drugs? And of course, from a overall disease outlook, this also suggests that maybe we do need to move that early on in the treatment of these patients. We might be able to see more of a benefit from those.
Right. And
Do you want me to just maybe briefly, I can tell you about the toxicity aspect as well. I think the biggest issue that we find from the trial, and that has implications for practice, is the ocular toxicity. Even though only a third of the patients had eye symptoms, nearly 2/3 of them had some findings in their eye, which is the basis for the current REMS program that goes with the drug, which does mandate that patients do have an eye exam before they receive each dose. And based on the toxicity pattern we have seen and how patients did on the DREAM2 study, there's a good possibility that maybe we don't need to give the drug every 3 weeks, but maybe, based on what we are seeing with the eye symptoms, it might get delayed up to 6 weeks between each dose, and still we may be able to retain the benefit.
okay. And which patients do you think or do you recommend would be the most appropriate to receive an anti-BCMA therapy?
Right now, we obviously, other than the belantamab, we cannot use any of the other anti-BCMA therapies in the clinic, but because nothing else has been approved. And for the belantamab, I think we are going to be able, literally at this point, sticking with the label, which means many of these patients are going to be later stage patients. Obviously, in the context of clinical trials, hopefully we can start treating some of these patients much early on, so that we can potentially, figure out how best to use this class of drug.